Biology here at JAX. It's my pleasure to welcome you to this symposium. So as many or all of you know, pain has become, in all its manifestations, has become a major health issue and a major societal issue that impacts the quality of lives of patients. It impacts the ability of healthcare providers to manage and to treat it, and it's certainly become a very important problem for society to deal with, the ramifications of it, such as rising levels of opioid addiction. And in addition, it varies across individuals how we develop pain, how we respond to pain, and so it puts this whole area squarely into what is now referred to as precision medicine, in trying to really tailor treatments and management individually to patients. A lot of research is being done in this area. A lot more needs to be done, and the purpose of this symposium is to give us a snapshot of the state of the art of the research that is being done at the molecular biology level, at the genetic level, at the policy level, and at the clinical level, and to hear from some of the leaders, international leaders in this field. So we've made this fairly broad to really cover the different spectra, and that's going to be the focus. So this would not have been possible without the generous support of the School of Nursing at UConn, the School of Medicine here at UConn Health, and the Jackson Laboratory for Genomic Medicine, in whose beautiful auditorium we're sitting at the moment. So I want to thank the leadership of those organizations, and I have two of the representatives here who want to say just a few words of welcome, and I'll start with Dr. Carol Polifroni, the Dean of the School of Nursing.
Thank you, Reinhard, and I too extend my thank you to Jackson Labs for enabling us to be in this excellent facility this morning. I'm happy to bring greetings to all of you from the UConn School of Nursing. While we're not located here on this particular campus, our scientists are here. Our scientists are here in the lab and in the clinical settings. And we're proud to be the host up in Stores of the first P20 on the UConn campus in more than a decade that addresses the Center for Accelerating Precision Pain Self-Management. And you'll hear from Dr. Starkweather later this morning as she and her colleagues are conducting several studies to advance theory-based symptom management, self-management interventions with a focus on pain improvement. Additionally, CAMP, which is also a center at the University of Connecticut School of Nursing, which is advancement in managing pain, and that's under the leadership of Dr. Kong and Assistant Director Dr. Young, who you will also hear from later today. And as we think about pain, we appreciate the fact that it's a multi-pronged process, if you will. And so you'll hear from Kyle Baumbauer, you'll hear from Dr. Sorge as it relates to diet, you'll hear from other people throughout the day as it addresses pain from all those mass varieties of perspectives. And so I want to say that as scientists, as clinicians, as practitioners, as nurse scholars, as all kinds of healthcare providers, that appreciation that pain is personal, pain is perception, and pain requires precision treatment. And so all those things will be talked about today, and I welcome you here, and I hope you enjoy the day. Thank you.
Thanks, Carol. And we have Dr. Larry Klobuchar here. He's the head of the neuroscience department, representing Dr. Bruce Liang, the dean of the School of Medicine.
Thank you. So on behalf of Dr. Liang, I want to welcome you all to the Pain Symposium today. And I don't think I need to tell this audience that while acute and chronic pain are long-standing problems in medicine, I think they've been underappreciated problems, and it's good to see that in the last 7 or 8 years, there's been an increased focus on research in pain, and so I think it's very timely that we have this symposium today. And the School of Medicine is certainly happy to be sponsoring it, along with the School of Nursing and JAX Labs. And I want to thank the organizers who I think have put together a very good program that represents the broad area of pain research that we've been talking about already this morning. And so Reinhard Laubenbacher from the JAX Laboratory, as well as the Center for Quantitative Medicine, is one of the organizers, but also Kyle Baumbauer and Erin Young from the School of Nursing, and also having joint appointments here at the UConn School of Medicine. So I won't keep you this morning, but I just want to say I think you're going to be hearing about a lot of good science that will stimulate, of which we hope you will stimulate your own further research. But we're also hoping that you make some great new interactions with individuals who will also have an impact on your research programs. So welcome again, and we hope you enjoy the talks in the day.
Terrific, thank you, Larry. And I should add, it really struck me reading what you wrote about why you're interested in this symposium when you registered, how many of you are really at in the trenches in dealing with this problem in one capacity or another. So I think this is a great audience for this topic. So let's move on. At this point we're still perfectly on time. We have Dr. Robert Sorge from University of Alabama, Birmingham, who will tell us about actually two really important topics that go together: diet and pain.
Thank you very much. Thank you, of course, to the organizers for putting together such a great program and for inviting me to come here. So I'm going to start into what the sort of programs that we've been working on at UAB. My interest is in diet and pain, and hopefully the take-home message you're going to get from this: what you eat really does matter. So I obviously don't need to tell anybody in this room that pain is a problem, but I feel like I always need to show one of these stats slides. So there it is. So for us, obesity is also one of the big issues. It's an issue for people across the world, Americans specifically. And so what this is showing is that obesity itself is a risk factor for chronic pain. So as your BMI, your body mass index, goes up, your risk of low back pain goes up. The graph on the bottom here, I don't know if this works. No, it doesn't. So the graph on the bottom here is showing through a survey of American adults, asked what your weight class is, what your obesity class is, and did you have pain yesterday? And so your odds of having pain yesterday go up in every age class with your level of obesity. And so it does seem like these two things are intertwined. Now, this is taken from the CDC. That's all right, I can point. So this is from the CDC. You just may not get me on camera the whole time. So from the CDC, this is looking at number of opioid prescriptions per state on the left, and then this is rate of obesity. And you'll notice that the states that have the highest levels of opioid prescriptions also tend to be the ones that are obese. And so my group down there in Alabama, lots and lots of opioids and lots of obesity. So we think that these two things are very linked. Now, of course, we can't say anything about causation, but we think that there is a definite link there. So the question that we had in my lab is, how does this poor diet or this obesogenic diet contribute to pain, and what does this do in rodents? So to start off, we used what was called the Total Western Diet. This was based on the National Health and Nutrition Examination Survey from 2011. So they took American adults, asked them what they ate, they figured out all the micro and macronutrients in their diet, and they created a diet that was the median value of all of those things. So this is sort of a median American diet. So we fed this to mice, and the mice changed over time. So over the 13 weeks that they were on the diet, now here we're looking at sensitivity to touch, and on the right, sensitivity to heat. And what you'll notice, those red squares go up. So what was happening over time is, as these animals were eating this diet, their sensitivity to touch and to heat decreased. So their thresholds went up. It took them more pressure to respond, and it took them longer to respond to heat. So this was changing how acute pain affects them. Now, of course, these animals, we expected that they were going to get fat. They did get fat, but what was interesting, they did not have more weight. So in terms of the actual body weight, there was no difference between the two groups. So they weighed the same. But those animals that were eating this total Western diet had more body fat. So this was changing the composition of their body. They were losing lean mass and they were gaining fat mass. Now, fat is also an organ that releases hormones and signals. One of those main signals is leptin. Leptin is an adipokine, it's a satiety signal, but it also has pro-inflammatory effects. And so what we're seeing here on the right is that after 16 weeks on the diet, these animals had a huge increase in the amount of leptin being released. Now, I said that leptin, of course, is a pro-inflammatory signal. Well, these animals also had an increase in pro-inflammatory cytokines. So what's really important to note here is that these animals have no pain. There's no observable pain phenotype at this point. So these animals are not showing any outward signs of pain, yet they are showing this sort of systemic inflammation. So increased levels of TNF-alpha, IL-6, and a slightly increased IL-1 beta. So they are inflamed. They're showing the sort of pro-inflammatory state even in the absence of pain. Now, what we like to do, of course, is to induce a chronic pain state and see how the animals respond to that. So for this, a lot of the stuff that I'm going to show you today, we use complete Frunz adjuvant, or CFA. It's heat-killed tuberculosis bacteria. We inject in the paw. It causes hypersensitivity that lasts for a week or so, and then the animals recover. So what you're looking at here, if you just pay attention to the open circles, we've got our control animals before the injection. After the injection, they're hypersensitive, so their thresholds are going down, and then they come back up. So this is sensitivity to touch, sensitivity to heat on the right. And so what you're seeing here is that the animals are hypersensitive. It lasts for about a week, 5 days to a week, and then our control animals come back to normal. But the animals that are on the total Western diet, it takes them much, much longer. Now they're starting from a higher place because their thresholds had changed over time, but it takes them much longer to recover. And so we're seeing recovery in 11 to 14 days in these animals. So effectively, a doubling of their recovery time. And so this was pretty big for us and very exciting. Now, that was a good experiment. It was a decent diet that we used, but we weren't necessarily keen on that diet because we were looking at it in terms of a translational perspective and thought, not a lot of Americans are eating these median values. People tend to be shifted to one side or the other, and we're really more interested in the people that are eating the really bad diet. So this is showing from these NHANES throughout the years, back in the 60s all the way to 2011, what Americans are eating. And so what you'll notice here is that in the 60s, Americans were eating more fat than carbohydrates. And at the same time, we're not overweight in general. Now, the American Heart Association came out in the early 60s and said, fats are bad, you should reduce your fats. And generally, over time, that's what Americans have been doing. They've been reducing their fats and increasing their carbohydrate intake. Now, very recently, it's come out that the Sugar Research Foundation suppressed a whole lot of data to sort of put the focus on fats. We now know that is not necessarily a good thing. So fats have been reduced over time, and at the same time, we see this dramatic rise in obesity. So we're thinking that it's the increase in carbohydrates that people are eating that are contributing to this. And of course, if you remember from grade school, or if your kids were in grade school, that food pyramid that everybody saw, where you had to have lots of breads and cereals, that was basically showing this sort of effect. So you're getting lots and lots of carbohydrates, and you're told to eat low fat. So we wanted to model an actual American diet in animals. So on the left here, you have an actual typical American diet. So it's very high in carbohydrates, decent amount of fat, very little protein. So this is the recommended levels from the Institute of Medicine. So you should have, roughly 50% of your calories coming from carbohydrates, a little from fat, a little from protein. Now, typically, when we look at obesity in animals, people use what's called a high-fat diet because, again, we've been told that fat is bad. So a high-fat diet is anywhere from 40 to 60% fat. Now, these diets do cause obesity in these animals. They can cause sort of pre-diabetes. But the problem we had with these diets is that the fat sources tend to be singular. So they tend to have almost all of the fat coming from lard. Now, lard isn't terribly good for you, but it's not a bad fat either. So this, again, is not really showing what is actually going on in a human population. People aren't eating big sticks of lard, hopefully. And they're not getting all their fat from one source. So we decided to create our own diet that was using multiple fat sources. So our diet is on the right. We called it the Standard American Diet because I wanted to call it SAD, and so that's what we did. So we used a bunch of different fat sources from soybean, corn oil, cottonseed oil, lard, beef tallow, milk fat. So it's a variety of different sources. We added trans fatty acids at a human relevant level, lots and lots of white flour, because of course that's what Americans eat a lot, or North Americans. And all the other ingredients, the vitamins and minerals, were similar to other diets. But what I really want to show here is the similarity between our diet and an actual American diet. It's almost identical in terms of where those calories are coming from. And so we think that this is a much better translational diet. So we fed this to mice. Here you've got males on the left, females on the right, and you can see that these mice got a lot bigger. So eating this high carbohydrate diet, these animals got very, very big, and they got big very, very fast. So females, we started to see differences after 2 to 3 weeks. Males took a little bit longer. After about 7 weeks, there were definitely group differences. Now, these animals are getting a lot bigger. They're also getting a whole lot fatter. So what was interesting here is the difference in weight between our control animals in the open and our SAD-fed animals. The difference in weight was almost exclusively fat. So every extra bit of weight that they put on was fat. So these animals were obese, and they had a whole lot of fat. In most cases, they almost doubled the percentage of body fat. Now, again, we did an injury, so we injected CFA in the paw, and we looked at hypersensitivity. Now we're just looking at sensitivity to touch. And so we've got males on the left, females on the right. Now, the open symbols are the control animals, and you'll notice they became hypersensitive, and they recovered in about 5 to 7 days. So this is normally what we see. But our animals fed this American diet took anywhere from 11 to 13 days. So again, we're seeing this doubling of recovery time that we saw with the other diet with our new diet. So again, we're seeing this massive change in the ability of these animals to recover from this injury. Now, with a high carbohydrate diet, of course, you end up with high blood glucose levels. So after an 8-hour fast, so these animals had not eaten for 8 hours, we tested their blood glucose levels, and we see significantly elevated blood glucose levels. So these animals are showing this high level of blood glucose, less action of insulin. When we inject glucose, you see this massive rise in blood glucose, which is signaling to us the beginnings of glucose intolerance, which is a precursor to type 2 diabetes. So these animals are getting to be glucose intolerant, seemingly getting towards type 2 diabetes. Now, also with this increase in fat, they have a massive increase in leptin. Now, with this increase in leptin, of course, we're thinking that this is also going to put them in this pro-inflammatory state. But we wanted to look at sort of the therapeutic side of diet as well. And so we created what we were calling our anti-inflammatory diet, or AID. Now, we had published in 2014 a paper looking at how different food sources interact with the immune system to reduce inflammation. And so this is one of our figures looking at how these different products interact with this inflammatory signaling pathway. And so what we did is we created a diet using a whole bunch of those things. Now, ours is a low glycemic diet, so it is a low carb diet. There's a decent amount of carbohydrates in it, but those carbohydrates tend to be resistant starches, which do not give you that spike in blood glucose. Now, we added omega-3s, we added green tea extract, EGCG, sulforaphane from broccoli, resveratrol from grapes, curcumin, and ginseng. And what was important to us is that we added these in human relevant amounts. So we didn't want to overwhelm them with any of these things, in the case that it might be something that you're not actually going to be able to get in your diet. So in the case of green tea extract, this is equivalent to about 6 cups a day. Now you may not drink 6 cups of green tea a day, but you could. For resveratrol, this is similar to about a cup of grapes. Now you may not eat a cup of grapes every day, but you certainly could. So this was important to us, that this diet was something that could be translatable. Well, when we fed this to the animals, what we found is that they did not gain a whole lot of weight, even though there was a decent amount of fat. So about 40% of their diet was fat, but they didn't really gain a whole lot of weight. So females are here, males are there. The males gained a little bit more weight, but it wasn't significantly different. When we looked at fat weight, the females did not gain more fat. The males did gain a little bit of fat. And so this was really interesting because, of course, our group is interested in sex differences. And there was a little bit of a sex difference here where the males were gaining weight, the females were not with this diet. Now, of course, when we looked at leptin, there really wasn't an effect on leptin either. Now, the interesting thing came when we did our injuries. So we're looking at this as sort of a preventative measure. So if you eat healthy all the time, do you get some benefit when it comes to an injury? Well, it looks like you may. So again, males on the left, females on the right. Looking at recovery time, the males recovered in about 5 days, so about a 2-day improvement. The females recovered in the same amount of time, but you'll notice that their hypersensitivity wasn't nearly as robust as the control animals. So for both males and females, this preventative diet did promote recovery. And so eating healthy all the time does seem to make a difference. But you may not want to do that. So what we wanted to mimic is this idea of using diet as an intervention. So the idea, of course, is that if you're injured or if you're undergoing surgery and there's a definite recovery time, if you switch your diet then, could that promote your recovery? And so the group that I want to draw your attention to is this last group. So they were eating the American diet, or SAD, for 15 weeks. On the day that they got CFA, they were switched over to the anti-inflammatory diet. So this is our intervention group. Now, when we did CFA in these animals, we see this dramatic recovery time. And so this was very exciting to us. Now, when you first look at this, you're going to look at that blue line and think, you know, it's not a whole lot better than the anti-inflammatory diet. And that's true. However, remember, these animals were in that red group. So they were eating the American diet, and we would expect them to recover in 11 to 13 days. They recovered in 5. So this is a dramatic improvement in their recovery just by switching the diet. Now we looked at blood glucose, and we saw something surprising there as well. So these animals were on this diet for only 2 weeks. After 15 weeks on an American diet, that was enough time to reverse this glucose intolerance. So that's the blue line. So these animals did not have higher levels of blood glucose at baseline and did not show this glucose intolerance after this injection of glucose. So just 2 weeks on a beneficial diet was enough to reverse some of those physiological changes. Now, we've also replicated this in other models. So this is a paw incision surgery model, so it's a model of post-surgical pain. We wanted to make sure that this translated across different injuries, and that is the case. So these animals were on our American diet for 12 weeks. We did the paw incision surgery, and you'll notice that our regular animals are recovering in about 5 to 6 days. Our animals on the American diet are recovering in 11. So again, we see this doubling of recovery time in other models of pain as well. Now, we were, of course, interested in the sort of translatable diet patterns because, of course, as an animal researcher, you're always accosted with this idea of how translatable is this. So we wanted to use something that we thought was more translatable. And I'm not going to take any credit for coming up with this. This was solely my grad student. She came up with this idea of a SAD weekend, which has a lot of justice to that name. So we wanted to mimic this idea of eating healthy throughout the week and then rewarding yourself by eating whatever you want on the weekend. Now that tends to be the diet that I use quite often, but it's not necessarily the best diet. And so the idea here is these animals are eating healthy throughout the week, and on the weekend they're getting this SAD, this American diet. And so the groups were here. So the first 3 groups are standard control groups, regular chow-fed animals, all the time, or all the time American diet, all the time anti-inflammatory diet. Then we have a group that got the regular chow Monday to Friday and the American diet on the weekend. And then the really interesting group, this healthy eating group that got the anti-inflammatory diet Monday to Friday and then the American diet on the weekend. Now, what was interesting here, this is just showing the males. The females show the same pattern. When we looked at weight gain, it was almost exactly what you'd expect. So the animals that got the American diet all the time, those were the heaviest. So that's the red triangles at the top. The animals that got the regular diet didn't gain very much weight at all. Anti-inflammatory diet, for the males, they did gain a little bit more weight, and that's what we saw before. But it's the other two groups, the yellow and the purple, that got the American diet just on the weekend, and they were, in every case, right between those two diets that they were getting. Now, what was really cool and really exciting about this is if we draw in on just those two diet groups, what you see is this scalloped pattern, where they would lose a little bit of weight, 1 to 2 grams, Monday to Friday when they were eating their boring or healthy diet, and then they'd splurge on the weekend, and they would gain 2 to 3 grams over 2 days. So this was a little bit of a model of binge eating. So these animals were gaining almost all of their weight just on the weekend. So that's when they got the good food, that's when they were gaining all their weight, and they were just sort of maintaining and losing a little bit of weight during the week. And so we do see this sort of scalloped pattern in both of these groups. Well, of course, we did our injury model. So again, we did CFA. We did the injury on a Thursday so we could test on Friday and then give them that weekend. So these are our 3 control groups, and we see the same thing that we'd seen before. So our anti-inflammatory diet, our preventative, they recovered in about 4 days. So again, this benefit of eating healthy all the time. Our control group, our regular diet-fed animals, recovered in 6 days, and our American diet-fed animals recovered in 13. So again, we see this doubling of recovery time when you're eating this bad diet. But what was really interesting was our group that was eating healthy during the week and then not so healthy on the weekend. And so this is the yellow line. So these animals showed lots of hypersensitivity. During this Monday to Friday in this first week, you see this nice recovery, so they're coming back. But then when they got this American diet, that stopped the recovery. And so we tested them again on the Monday. There was no recovery between Monday and Friday. So this diet halted this recovery. And then, of course, when they went back on the diet, they recovered again. Now, this was, of course, disheartening because this meant that if you ate healthy during the week and splurged on the weekend, it was just the same as just eating healthy all the time, so why bother? So that was a little bit disheartening. But there were some differences between these groups. And so we've started looking at the microbiome. And so what we did is this is broken down just by the phyla between these groups. And what's interesting is you do notice very striking differences between these groups in terms of the relative proportion of these phyla. And so if we pay attention just to the American diet and the anti-inflammatory diet, you'll notice that the relative proportion of a lot of these phyla are very, very different between these groups. And they're very different in some really meaningful ways, and I'm going to get to that in a second. But what also is very interesting here is that the groups that got a combination of the two diets also show this sort of combination of these phyla. So you end up with the SAD-A. Most of these bacteria are sort of a middle mix between those two diets, which is very interesting. So yes, you may recover in the same amount of time as if you were eating bad all the time, but in terms of your microbiome, you do get some benefits. Now, in terms of some of the benefits or what the benefits might be, we're looking at some human data. So in this experiment here, they had people, obese individuals, go on a diet for a year, and they looked at the relative proportion of Firmicutes and Bacteroidetes in their stool samples. And what you notice here is that as these individuals became more lean, lost a lot of weight, you see a reduction in Firmicutes and an increase in Bacteroidetes. Now, when we compare those same groups in our animals, you'll notice we see a very similar thing. So our American diet-fed animals have got lots and lots of Firmicutes, relatively low amounts of Bacteroidetes. are anti-inflammatory diet animals or healthy diets, we see this ratio shifting in the same way that it did in humans. And so we're thinking that this may be a very good translatable model. Now, I'd be remiss if I didn't mention this, because this is what we've been doing for years now. And this is, of course, a very accepted thing, that the immune system has a very major impact on pain. Hopefully I don't have to convince anyone of that. But this, some of the new highlights or the spotlight on this came from some of our work a few years ago, where we found that if you induce a chronic pain state, in this case it's a spared nerve injury, so these animals are hypersensitive, if you inject glial inhibitors into the spinal cord, you reverse this pain. Now this has been known for years and years and years, that you get this, there we go, we'll try to use this. So you get this reversal of pain. So these animals show less pain, and then this goes away. So we've known for years that this works. If you block microglia, you reverse pain. But what we found out is that this was only the case for males. So none of these drugs worked for females whatsoever. So this showed us that there was this sex difference in terms of when these drugs are working. And now this is, of course, a huge problem. Hopefully I don't have to convince anyone of this. Most of the clinical pain population tends to be female. So if we're testing all of these drugs in males, it may only apply to a small percentage of this population. Now, we tested a whole bunch of other drugs looking at different receptors on microglia, and found that for all of these other drugs, they only worked for males, they never worked for females. So this is reversal of pain, or anti-allodynia. The only drug that worked for males and females was a drug that blocks neural transmission. So if we block the transmission from the spinal cord, then we block pain in both males and females. But if you're specific to just the microglia, it only works in the males. Now, since we've published this, Rurong-G's group has also shown very similar things. So if they do a nerve injury, they see an upregulation in microglia in both the males and the females in the same side, or the ipsilateral side of that injury. So we saw the same thing. We see an upregulation in microglia, so more of the microglia are active. But what Rurong-G's group showed is that only in the males are those intracellular pathways being activated. So the cells are being activated, but they're not doing anything in the females. And so overall, we have this idea that it comes down to testosterone. If you have high levels of testosterone, as you would in a male, you'll use this microglial system. If you have low levels, as in a female, you'll use T cells to mediate this pain. And you can shift these systems back and forth by adding T cells, taking away T cells, adding testosterone, or taking away testosterone. So what's really important here is that both males and females have both of these systems, but they preferentially use one or the other based on their hormonal state. So the question we wanted to ask, of course, is that what effect does this have on the immune system? So we see this prolongation of recovery, but what is this doing to the immune system? Well, so we did this study in rats, primarily because it's a lot easier to look at spinal cords in rats than it is in mice. And so what we did is we fed our diet to rats over 20 weeks. By the end of the experiment, they had gone on for 26 weeks, so a full half year of these rats getting fat. And what was interesting here is that at the 20-week point, so when we imaged these animals for body fat, there was no difference in the males at the top or the females at the bottom. There was no difference in body weight, nothing statistical between those animals. So the animals were not bigger when they were on this diet, which was a little bit shocking to us. However, when we imaged their fat, what you'll notice here on the right is that for both males and females, they had this dramatic increase in body fat. Now, remember, this is happening without a change in weight. So when you get an increase in body fat, you need to decrease something else, and they did have a significant decrease in lean mass and in bone mineral density. So this was changing the composition of their body without necessarily changing their weight. So again, having this very dramatic effect on their bodies. And of course, we wanted to look at their inflammatory state. And so we looked at a bunch of these different mediators in both males and females. You'll notice a whole bunch of stars there, but just to sort of bring it together, These are the different mediators that we looked at, their function in terms of whether they're traditionally anti-inflammatory or pro-inflammatory, and what the source of those mediators might be. Now, what I want to draw your attention to is that there are only very few that were upregulated in both males and females, and those are our standard classical pro-inflammatory signalers. Now, those are released by a number of different cell types. Now, in the top part, these are the mediators that were found to be upregulated only in the females. And what's interesting here is that most of these can be released specifically by T cells. And so again, we may be seeing this sex difference in terms of which cells are being activated in males versus females. And so for females, this diet may be activating T cells, and we're getting these T cell mediators upregulated. For males, we're activating microglia, and we're seeing these more traditional microglial activators. Well, of course, we induced a chronic nerve or a chronic injury with CFA, and if we group the two males and females together, again, you see the same sort of thing that we saw in the mice, where we see this recovery in our control animals in about 3 weeks, with sort of recovery starting after about a week. But our animals on this American diet took 40 days to recover. So again, we get this almost doubling of recovery time. So now it's not only across different diets, but it's across species as well. Now, what's interesting here, of course, is that our control animals start this recovery after a week. Our animals on the American diet don't start recovering until almost 2 weeks in. So again, this is changing their ability to come back from this injury. Now, if we break this down by sex, it looks a little bit messier, but again, you see this general difference where the control animals are recovering in a decent amount of time. Our animals on this American diet are taking a lot longer. And this is very dramatic if you compare the males, so the two blue square groups. So our control males, again, are recovering relatively quickly, but our males that are on this American diet, and I'm going to run out of the screen for a second, are taking just over 5 weeks before they start recovering, or almost 5 weeks before this recovery starts. So that is a long time to be maximally hypersensitive. So this is having, again, this dramatic effect. But what is it doing to the immune system? That's why we did this study. So we looked at the spinal cord in the dorsal horn between L4 to L6. And what we see is this. So we're just looking at number of labeled microglia or macrophages with IBA1. And what we're seeing here is a doubling of the number of activated cells. Now, this is at the point a week following the recovery after CFA, so these animals are no longer in this pain state, but we're still seeing this doubling of the amount of activated microglia. Now, of course, we have received some comments. Well, how do you know this isn't a residual effect of CFA? Well, we've subsequently looked at just exposing them to diet for 8 weeks or 16 weeks, and we see the same thing. So if these animals had never had a pain state induced, we still see this upregulation in labeled cells. So our hypothesis right now is that the American diet is chronically activating microglia and macrophages, activating the immune system, and it's leaving the animal in this primed state, so that if there's an injury, the immune system hyper-reacts, has this overreaction, and we do see this prolongation of recovery and this increase in inflammation. So that's our hypothesis. Now, we've also started to look at flow cytometry. So we're interested to see what effect this diet is having on T cells, specifically in the spinal cord, because we know that females tend to use T cells to mediate their pain. So what is this doing to T cells? Now, we started off by taking some animals from a collaborator. So these are animals that are obese. They were fed a high-fat diet and are obese. And what we see after about 16 weeks on this diet, the obese individuals have less helper T cells, more cytotoxic T cells, and more microglia in the spinal cord. So this, again, is exactly what we would have expected. So this, again, is sort of replicating what we've seen in immunohistochemistry, where you have an increase in microglia or activated microglia in the spinal cord after this diet. But now we're also seeing this dramatic shift in the types of T cells that are infiltrating into the spinal cord. Now, we've started looking at our diet. So this is just after 3 days because we wanted to see if there was any acute effects of the diet, and it didn't look like there was. Actually, right about now, my students are taking out spinal cords from animals that have been on the diet for 16 weeks. And so hopefully in the next week or two, I'll be able to tell you what's happening after 15 to 16 weeks on this diet. So again, we're seeing this change where we have an increase in microglia in the spinal cord after this diet, and we're hoping to also see differences in T-cell infiltration. Now, as an animal researcher, the question we often get, does any of this translate to human? Is there any translatability whatsoever between the stuff that we do in animals and what might be going on in people? Well, remember I said that carbohydrates are what we think is the problem. So as carbohydrate intake has gone up, so has obesity. And just to hammer this point home, the other day I went on a parenting website to see what these parenting websites are telling parents to give their kids, and this is still there. So this food pyramid that has been out of date for at least 10 years is still being shown to parents, and so again, they're being told to give their kids lots of bread, cereals, and potatoes, which are very, very high in carbohydrates and cause a massive spike in blood glucose and insulin. This is not the sort of diet that you should be feeding your kids. So we were interested in what these sort of diets might do to humans. So we took older adults, 65 to 75 years of age, with knee osteoarthritis pain. We had almost equal amounts of males and females. This is a very small pilot study, and we put them into 3 groups. So the first group was a control group where they were just told to eat whatever they normally eat. The next group was a calorie-reduced diet. So if you're male, you had to reduce your calories by 500 calories a day. Female was 350 a day. So this is our sort of weight loss control. So this is the standard weight loss diet to make sure that any effects that we get may not be due to weight. And the last group was our low carbohydrate diet. So because we think carbohydrates are the problem, we wanted to reduce that. So these individuals were told to reduce their carbohydrates to 20 grams a day or less for the first 3 weeks. Now, an apple has about 20 grams a day, or 20 grams, so you do have to really reduce it. It's not an easy diet to do. But then after the first 3 weeks, they're allowed to go up to 30 to 40 grams as necessary. Now, during the course of this 12 weeks, they came in every 3 weeks. We took blood every once in a while. They filled out surveys, and we did functional testing. So that was something that we thought was going to be a lot different than a lot of previous studies. So a lot of studies have looked at pain and sort of self-reported pain, but we were interested in the functional pain. Do they have less pain when they do things? So these are older adults. What is happening when they're actually being active and doing the sort of things that they might be doing on an everyday basis? Do they have less pain? So first, looking at weight, both of our diet groups lost weight, and there was no significant difference between the weight loss between these groups. Now, this was really exciting because this then meant that any differences between the diet on our pain scales would be due to the diets themselves and not necessarily weight loss. Now, of course, we're looking at the knee, and losing weight does change your pain in this weight-bearing joint. But both groups are losing weight. So their weight is going down, their BMI is going down, but when we split this up by sex, now remember there's only 6 to 8 people per group, and so we're looking at 3 to 4 men and women in each group, so it's not a lot to say anything, but the women seem to be enjoying more weight loss than the men. So in both of these diet groups, women are losing more weight than the men. So a little bit of a sex difference there. When we looked at the surveys and the questionnaires, we were a little bit disheartened. So this is the brief pain inventory looking at daily pain and pain interference. And these are changes. So these are different scores between the baseline and at the end of the intervention. We see no effect on daily pain. We see a hint of an effect on pain interference. So our low carb group seems to show a reduction in pain interference. So this means, does the pain that you feel in your knee interfere with daily activities, going for a walk, doing the laundry, that sort of thing? So a hint of an effect there, but nothing significant. When we looked at a survey specifically for knee osteoarthritis, we see no effect on pain, not really any effect on quality of life unless you try comparing just the two diet groups, but again, nothing is significant. So again, a little bit disheartening. These sort of self-reported measures don't really seem to bear out. Depression was also something we were interested in because, of course, food is very closely related to mood. And if you have to reduce the sort of yummy things that you like to eat, that may have an impact on depression. And in fact, looking across the weeks, it did have a little bit of an impact. So only our group and the low-carb group showed this little spike. So the first 3 weeks are hard. So eating less than 20 grams a day of carbohydrates is really tough. And so we were getting anecdotal reports of subjects, having a hard time getting through this, and that bared out when we looked at depression scores. So none of these individuals are depressed, but their depression severity did increase a little bit in that first 3 weeks, and then when they sort of got into this diet, we see this decrease. Now, when we compare beginning to the end, we don't see any significant effects, but the low-carb group did show the most dramatic drop in depression. So that was a little bit good. Where we really saw differences that we were excited about was in the functional pain tests. So these are people with knee pain. A chair stands test means that they sit in a chair and they have to stand up 5 times in a row as fast as possible without using your arms. Now, if you've got knee pain, that hurts. The other test we did was temporal summation. So we took a little fiber and we poked them 10 times in a row on their sore knee. Subjects don't like that very much. So what we're looking at here is the change in their pain intensity rating. So they were asked to rate the pain in their knee before we did it and after, and we take that as a difference score. So that is our evoked pain score. And then this is looking at the difference in those different scores between the beginning and the end. So reductions are good. And so what we saw here is that our low-carb diet showed the most dramatic reductions in functional pain. Now, this was really exciting to us because, remember, both diet groups lost weight, but the calorie-reduced diet did not show these same reductions. So we have pretty good evidence to say that it was the quality of the diet, the type of food they were eating, not the weight loss that was giving us this beneficial effect. Now, again, when we looked between males and females, again, females were losing more weight than the men. They also seemed to be driving this effect. So the females were showing a dramatic reduction in functional pain, men not so much. So again, we see this hint of a sex difference here, where these diets may be more beneficial to females than they are to men. Now, because the chronic pain population is primarily female, this may not be a bad thing, unless you're a man with pain. So this diet, of course, with this reduction in weight, also led to a reduction in leptin. Again, now what's really interesting here is that the calorie-reduced group also lost weight, but did not show significantly decreased leptin levels. Now, this, of course, comes back to the source of leptin. So in our low-carb group, this suggests that these people were losing fat. And with reducing that fat, they get reduced amounts of leptin. Our calorie-reduced group lost weight, but it may not have all been fat. It could have been lean mass, it could have been some fat, it could have been body water retention. So again, we're seeing this difference in how these diets are changing physiology. Now, we wanted to hope that this was an anti-inflammatory diet, but in terms of markers of inflammation, not so much. So it was reducing functional pain, but having no impact whatsoever on any of the markers that we looked at. So it did not seem to reduce systemic inflammation. Now we think we have an idea what it might be doing, and we think this is oxidative stress mediating this effect, but not inflammation as we standardly measure it. So some final thoughts before I wrap up. Hopefully I've convinced you that diet has a very big effect on behavior and physiology, and we think that's having this effect primarily through the immune system. Hopefully I've also convinced you that diets can be used as preventatives or as interventions, and that seems to be the case in both preclinical and clinical models. And in this era of an opioid epidemic, diets may be an alternative strategy to reduce mild to moderate chronic pain as an alternative to some of these opioids. So hopefully I've convinced you of that. The diet does have an impact and it can be used as a treatment. I want to acknowledge all the people that did it, and my collaborators and my funding sources, and I'd be happy to take any questions.
Time for a few questions. Since this is being recorded, if you have a question and you could use the microphone, that'd be terrific.
Wonderful presentation, thank you. I have a question regarding when you're looking at the microbiome, what were the exercise regimens for the animals, and did you see any effects on that? And then have you looked at any type of stress like that would translate to humans, such as social determinants in the animal models that might change microbiome effects on diet?
So that's a really good one. We have not done any of those sort of effects. So we haven't looked at stress. The only stressor would be our chronic pain induction. And in terms of exercise, these animals did not exercise any more than they could in their cages. So they were in our traditional shoebox cages, no extra exercise. So we're hoping that most of these effects are due primarily to the diet and not to any sort of external environmental effects.
So, from a clinical standpoint, so I have parents and kids who come to my clinic all the time, and they do ask about diet, and most of the time I shrug my shoulders because I really don't know the answer. So I guess the question would be, as of today, if somebody comes to my clinic, what do I tell them? And how do I get them to stay on a diet, since I can't get most patients to comply with a lot of my recommendations?
So that of course is a big problem. And so, with any diet, for it to really be effective, it needs to be a real lifestyle change, which is very difficult. Now, one of the things that we did in our clinical trial was if we had a husband and wife come in together, they were necessarily put on the same diet, and we wanted to make sure that the individuals that did come in, they were not reliant on anyone else for meal preparation, because it is something that does need to be done, and you need to have all groups committed to it. Now, in dealing with children, I think the biggest impact is going to be convincing the parents to follow this, and it may be something that the whole family has to do in order for this actually to be effective. But I would recommend a low-carb diet. So ketogenic diets or low-carb diets are used for seizures for children with epilepsy. So it is possible, but it does need to be a real lifestyle change. And I mean, it will take convincing, I think, the parents above anything else than the kids.
So you used the word priming at some point in your talk. So I have to ask you the question. So number one, have you tried to see if you put animals on the diet, and because you're moving to a slide tells me you have tried this. So if you put animals on the diet and you give them a subthreshold dose of inflammatory mediators, do they respond like they'd had a previous injury? And number two, if you do CFA and then you test for priming using the model like described by John Levine, do you see that is enhanced by the diet?
So we haven't done the CFA and then test them. But what we have done is we have done the sort of priming model with IL-6 and PGE2. So on the left-hand side, these are animals that are on the SAD and the regular diet during this first IL-6 injection. And this is, of course, the difference in their thresholds after this injection. And you will notice that the animals that were on the SAD that got IL-6 do show a reduction an hour after this injection. And so they do show this hypersensitivity. When we do PGE2, we see this hyperalgesic priming in this group, our control group, and we see a little bit more of a response in our SAD-fed animals. But our sad animals that got saline in the first case are also showing this hyperalgesia to PGE2. So we are seeing a little bit of this priming effect, but we haven't done sort of two different injuries.
We tried to look at the duration of the PG2 induced effect. So you see an effect early. Right. If you look, can you see that it lasts for much longer than it does in the animals on the normal diet?
We didn't notice that it went any longer.
Okay.
We didn't do a whole lot of time points. We did an hour and 3 hours after, and we've actually done faces with them. So we're looking at grimace, and we're analyzing that right now.
Yeah, Robert, thank you. I, have a similar, I guess, clinically oriented question. So within the anti-inflammatory diet, if you were to translate that into human consumption, and that beautiful slide that you showed, through IKB, a number of factors sort of coming into play, grapeseed extract, et cetera, what would be the recommendation in the way of diet for an individual, for the general population, that begins to mimic the AID diet? Is it, a bowl of, grapes and 6 cups of tea? And maybe gets a little personal to the point where I'm curious what you now do, given your own knowledge in this area. So
yes, I should be following this diet. I do know. I have tried to reduce my carbohydrate intake, but times like this, it's a little hard when it's you're up for a great dinner. But yeah, I have tried to reduce my own carbohydrate intake. But in terms of clinically trying to follow this diet, I mean, like I said, it does have to be a lifestyle change. And to mimic our anti-inflammatory diet, we had it at levels that you could do. Now, again, the idea of, do you need to eat a cup of grapes every day? Maybe you don't need to. Maybe you can switch it up. I mean, lots of other fruits and vegetables do have these anti-inflammatory effects. Blueberries do, strawberries do. And so you can mix it up. So realistically, a diet that is high in fruits and vegetables tends to be anti-inflammatory. So that sort of traditional Mediterranean diet, high in fish, high in fruits, high in vegetables, does tend to be very anti-inflammatory. And so a diet of that sort should give you very similar results.
I don't know if I can be quick, but thank you, Rob. It's great talk, and always thank you for making me feel bad about my food choices. To follow Ted, you used the word physiology, so I'm going to ask the question. What's going on in the afferents or even in the central neurons? You showed there's an effect of glia. Does that modulate anything that's going on in the neurons? Is it peripheral, central, both?
We don't know.
Awesome.
I would love to find out if you're interested in doing so.
I can do that, yeah.
But yeah, I mean, we're hoping that there is something going on, whether these neurons are more excitable due to the fact that these immune cells are more activated, lower thresholds for excitation. I mean, that's what we're hoping is going on, or we're thinking is going on, but we haven't tested it yet. We're not equipped to do that.
And trying to see how to make this. Oh, you got one. Okay.
Oh, great.
Terrific. Very good. Our next speaker is Dr. Starkweather from our very own School of Nursing.
Thank you. Good morning, everybody. I just want to see from our audience today, how many clinicians, just clinicians are here, and how many clinician researchers? Great, okay. And then how many just basic research, or, okay, great, all right. So a good mixture today. I'm coming from a background as an acute care nurse practitioner working with neurosurgery patients, and those patients would come in for low back surgery, often with some deficits. And from the clinical standpoint, it was really, really hard. We knew that about 10% of those patients that would come into the clinic would actually need surgery. And then the rest of them just had to deal with what they were going through. And learning how to manage that type of scenario really hit home for me as a clinician. And so it really got me into looking at musculoskeletal pain as my topic of interest. So I don't have any disclosures to announce, but I want to just go ahead and let you know the objectives of what I'm going to be presenting today is really about my most recent research, and then looking at what is going on at UConn School of Nursing and across campuses at the School of Medicine as well, and give you some ideas of how you might want to be involved in what's going on. As Rob talked about, this chronic pain is a really significant issue in America. It affects millions of people, and low back pain is one of those very high impact conditions. When we look at low back pain, it's a very heterogeneous condition though. So we know that it might just be musculoskeletal, it might have some neuropathic components to it, sciatica being involved. But it's very, very high cost, and there's a lot of different treatments. We don't know at this stage what treatment is going to be best for the person that presents in front of us. And so that's really where we're wanting to go with this program of research. So we know physiologically that there's different types of pain, but again, as a clinician, when I'm assessing a patient with pain, the difference between nociceptive and neuropathic might be evident, but what's going on physiologically, biologically is not always known. And again, using some of the best technology that we have for imaging, I might not be able to see what is compressing the nerve or what is going on biologically to produce the pain that's occurring. So what we know at this time, using the biopsychosocial model of pain, we know that there are a lot of different factors involved, psychosocial issues, as well as genetic and biological issues that might increase the likelihood of having a chronic pain condition. When we look at the sensitization that occurs in these patients, we have recognized patterns where a highly sensitized person might be more at risk of having a chronic pain condition. And so our ability to quantify that will help us as clinicians to then recognize, are we dealing with somebody that is at higher risk, and do we need to monitor them more? Do we need to have more aggressive therapies to help reduce the chances that they will have a chronic pain condition? So we're really working from that stance in terms of where we're going with this. Through an R01 funded study through National Institute of Nursing Research, we were able to look at the psychosocial, somatosensory, and genetic influences of a chronic pain trajectory in low back pain. So this is simple musculoskeletal low back pain patients that came in. We had 220 patients, and I was able to finish this project here with Erin and Kyle, and Vivian, a bunch of my team members are here. So what we did is very reminiscent of the OPERA study that Bill has overseen. We just took a general acute low back pain patients that came in, and we would do both blood, somatosensory profile, as well as psychosocial profile on these patients. And we would follow them every 6 weeks until they either resolved and didn't have any pain any longer, or until they continued for 6 months. And so 6 months is quite a longer period of time when you look at chronic low back pain, but we wanted to really make sure that that was the trajectory that they were on. Typically in clinical practice, we tell patients, about 90% of patients resolve within 6 weeks. Just do what you're prescribed to do, increase your level of physical activity, which is often hard for them to do anyway, and take your pain medication. So if that's ibuprofen, hopefully not opioids, but looking at some other analgesics to help reduce the pain. And so generally in the literature, it's about 90% of patients will resolve within that 6 weeks. And we wanted to see if we could differentiate when that patient came in, whether they had a differential somatosensory profile as well. And we know that there's psychosocial issues that can increase risk, and then their genetic profile. So looking at the study protocol, we had these 220 patients that would come in. At least for that first initial visit, they had everything done, and then every 6 weeks they would continue until they either resolved their pain or continued with low back pain. So those of you who aren't in research but are doing clinical practice, we do the somatosensory testing as a very, think of it as an enhanced neurological exam where we're using very standardized measures to look at both localized pain as well as generalized pain. And when we look at the pain site or the pain site, the localized site, we're applying stimuli to the area of pain that they're having, thinking this is normal. They're having sensory changes with that pain that's occurring. When we look at the remote site, the site away from the pain, this can be a sign that there's actually more centralized pain issues going on, that sensitized state that we're talking about before, where we're looking at that might be a higher risk factor for those patients if they have centralized conditions going on. So when we look at some of the differences between the patients that resolved within 6 weeks and the patients that went on to have 6 months of chronic pain, we did detect some differences in the somatosensory profile. And the ones that I would just draw your attention to are the cold pain threshold. Both areas, so both the localized as well as the centralized pain, was a difference between those two populations. When we look at mechanical pain sensitivity, this is just applying one of the fibers to the area of pain as well as the area of remote site, which is their forearm. We saw that there were increased sensitivity at both sites. And then looking at pressure pain as well, and we apply this with an algometer, we saw a difference of pressure pain away from the site of pain. So again, indicating that there might be some centralized pain going on or increased risk in those patients that went on for a chronic pain trajectory. So we know from the biopsychosocial model that there are certain conditions that increase that risk of chronic pain. And we wondered then, applying this to this population of 220, what would be the probability that a patient would recover by 6 weeks, or what were those factors that would really affect that trajectory? And older age came up as the most significant thing within the 6 weeks. Within 12 weeks, the thermal pain was part of the predictor as well as reactivity. So those psychosocial or psychological issues really started to crop up. And then when you looked at the probability that a patient would recover by 18 weeks, it was really all psychological. So giving us a little bit of an indication of those factors that are really impactful as the patient progresses in their pain. When we look at the genetic contribution, and we were using at this time PCR to look at gene expression. And there might be some controversy in the way that we're doing this because we have this debate with our team all the time, whether you can actually look at something that's happening regarding pain outside of the neurological system. We're looking at gene expression and using a priori selected genes that we know that are involved in pain, and looking at using PCR again to amplify specific regions of the gene. What we saw was one specific gene, PTGS, which is a protein expressing gene of prostaglandin E synthase, and you'll hear more about that in just a minute. And so of those 86 genes on that profile, that was the one that differentiated those acute from the chronic pain population. And so we've been a little bit hesitant to publish on this yet because, as you'll hear probably from Luda later today, we don't think it's just one gene. And so looking at these profiles where they've already selected the genes that we're looking at, we really wanted to take this further and do some more studies within the broader interactions that are going on. So we're working with Susan Dorsey at her lab at University of Maryland, Baltimore, to do some further work with her. As you already heard about, that PGE2 is one of the factors that Rob just talked about, and looking at whether that gene could actually increase levels within circulation is something that we wanted to follow up on. And so we did a little bit of metabolomics or lipidomics on this population as well. And we know that arachidonic acid is a big factor in causing acute pain, but didn't know if it would then affect a chronic pain trajectory. Recognizing that this was just the levels at the point of when that patient came into us the first time. So we wanted to look at the difference between patients that, again, had an acute recovery versus a 6-month trajectory of pain. And so what we saw in that, looking at our normal controls versus acute versus chronic, we saw a significant difference between the acute and chronic group at the point where they came in to see us with that pain condition. With our bioinformatics collaborators, we're able to then look at what's going on in the lipidome at the point of when the patient comes in, and able to look at what that network of different sphingolipids are. We know that sphingolipids and the ceramides in particular are intimately involved with pain signaling, and so when we looked at the different levels of ceramide, we saw, again, a significant difference between the acute and chronic group as they came in to the clinic. So as we look at what we're able to do with this data, this is just a slide depicting what we know right now in looking at LDL levels. For chronic pain, we do have the capability, I think, to get there to the level of precision where we're able to look at, as you just heard about, dietary factors, and look at what's going on in circulation to the point where we can give some recommendations on changing diet, on changing exercise regimens. And right now we're at the capability of doing some pharmacological or pharmacogenetic recommendations as well. So we're getting there in terms of our precision in pain management, but we have a ways to go. What this, again, one study of among many that we're going to be doing has shown, though, that when you have a patient that comes in with an acute low back pain episode, they might have those indicators at the point of time where they're right in front of you, which would give us, again, that ability to have increased monitoring, have increased interventions for that specific patient. Where we need to go is what are those specific interventions that are going to help reduce their chronic pain trajectory. So hopefully in the future we're able to use this type of pain phenotyping in the clinic where we're being able to predict what trajectory they're on and deliver then really targeted therapeutics so that we're able to reduce their chances of a chronic pain trajectory. We're using right now, working with some of our collaborators on some mHealth techniques for interventions, helping patients to monitor better their own pain and looking at how we can use these technologies to reduce a chronic pain trajectory as well. And as you heard this morning, there's some dietary interventions that we could be incorporating with these. In our own center, we're using the IFSMT, which is the individual and family self-management theory on behavior change. It's all about behavior change and looking at how we can use these diagnostics to then target the therapy that we're giving to that patient and helping them to then incorporate it into their daily life. As you heard about, changing diet even is a really hard thing to do, but we know that other factors affect pain, such as sleep, our own emotional state, and things that patient and family could be doing to help reduce their chances of having a chronic pain trajectory. It makes me really hopeful that we've got, the now federal national pain strategy that is out, and a lot of these even policy issues that we could be really implementing in our communities to help protect patients, to help prevent a chronic pain trajectory are really coming to fruition, and I'm hopeful in the future that we're going to be able to use these techniques and these strategies to help even populations. What we're doing right now in our P20 Center for Accelerating Precision Pain Self-Management, this is again sponsored by the National Institute of Nursing Research, is doing just that with different protocols. So we've got 2 protocols going on right now, one where we're working with Dr. Young with patients with irritable bowel syndrome. Dr. Xiaomei Kong is directing that, and we're looking at the trajectory for those patients, and again, using behavior change to reduce stress, reduce some of the inflammatory diet that they're often eating, and helping to reduce symptoms. Xiaomei Kong is not here today. She's actually submitting another P20 today, so fingers crossed that we're going to go forward with that, really looking at the microbiome and pain as well as fatigue in multiple chronic conditions. And so she sends her best wishes, but she is now the director for the Center for Advancement in Managing Pain, along with Dr. Erin Young. And we have really that capability of housing an interdisciplinary team of scientists to share ideas and keep alert of the latest in what's going on with in pain. And with that, we have 2 biobehavioral labs across the 2 campuses. We have one here on the 4th floor of the outpatient hospital, as well as in the School of Nursing, where we do all of our somatosensory testing, all of our blood draws. And it's a great place to be because we've got that ability to go interdisciplinary as well as translationally, working with our colleagues, these cool people here, Erin and Kyle, in their lab, in being able to translate this back to the animal models to see what specific mechanisms that we're touching on, and then back into the clinical settings. So we've got that capability here and that infrastructure to really carry this forward. I couldn't do this without my collaborators, Dr. Susan Dorsey, who's right now doing all of our sequencing, and we're hopeful that, again, we can be able to identify a specific profile for patients that are coming in with chronic pain or with acute pain, and be able to prevent then a chronic pain trajectory. We're working across different populations, so patients with cancer, patients with fracture as well, and being able to look across these populations for the different profiles will, I think, hopefully enlighten us to how these different pain conditions or stressors can influence a chronic trajectory. As well as Deb Lyon, who works with us down at University of Florida in cancer pain. So thank you very much. That's wonderful to be here.
It's so exciting to hear this going on. So exciting to hear this going on, and I mentioned last night's wonderful dinner. It's terrific to see this happening in nursing. Just interested in the naming of your center, Precision Pain Self-Management. I'll talk later about this. I see self-management as important. It was labeled in the IOM report, the National Pain Strategy. It's highlighted again in the Federal Pain Research Strategy. And I think it, in my mind, is mostly consistent with acknowledging pain as a public health problem and a public health concern, and self-management in particular as being promoted at the level of, in a way that's consistent with that is a broad concern. What I'd like to see happen in this country actually is money being put into a public health campaign, public media campaign, as they've done in Australia and in other places in the world, to try to tackle this at a population health level. That seems, to me anyway, inconsistent with the idea of precision, which seems to be focused at least on the individual or subgroups of people at the very least, if not even at a biological level or a biopsychosocial level, kind of within the individual. So I'm just curious about your choice of that name other than the politically obvious one, which is labeling something as consistent with precision medicine draws money now.
Right now it's the sexy term, right? So our selection of really looking at precision in self-management, we know that self-management overall, there's umbrellas, ways that we can do health promoting endeavors that are important for all of us. But how important they are to that patient that comes in front of us with an acute pain condition is unknown right now. And so by being more precise, by being able to use some of, Kyle hates this term, biomarkers, but being able to use some of the indicators for that patient that's in front of us and being able to then select what self-management strategies are going to be most effective for them is where we wanted to go with that. So yes, there are some general population considerations for self-management, but we want to be more precise in the way that that patient comes in at that point of time so that we can prevent chronic pain from occurring. That sensitization state that we're seeing over and over again.
Yeah, Angela, thank you. Very, very nice. I'm curious as you move forward with this, as a sort of a challenge for the field, as to how you see this moving forward, getting beyond barriers where you go to point of service. So how do you conceptualize translating your findings to very busy clinics, providing information at point of service in a way that will I think, help both patient and clinicians in this area?
Yes, they've done such a great job of promoting the Precision Medicine Initiative and really precision health, but didn't really think about that, how it's going to be disseminated and the impact on us as clinicians, as patients and families who are healthcare consumers. And that is a very big, I think, attention of the national academies right now, and something that we're working with within our committees to address. So very good question again, and I think we're moving forward. There are some healthcare centers that are selecting some pharmacogenomic testing so that they are being able to test the delivery of that to the clinician that's then being able to provide information and changes in medication regimes, as well as patient behavior, how they're addressing that in their own decisions. So some of that is trickling down into being more precise and being able to deliver that information to the clinician, then to the patient, and then those health behavior indicators. We're starting to collect some of that, and we're starting to see the impacts. How I see it right now, if we're able to decipher a specific assessment that clinicians are able to give that have a indication of a higher risk of a chronic pain trajectory, being able to do some genetic tests, an assay that you can do at point of testing, and see if the treatment that you're using at that point in time is reducing the biological effects or the biological underpinnings of that chronic pain. I think there's some ways that we need to go in terms of that translational step. That doesn't. I think it's on a more global scale on the whole Precision Medicine Initiative. I think that it's very much applicable here as well. So I think it's being addressed. We've got some barriers in terms of costs. What I'm most concerned about is actually for our disadvantaged patients that don't have the means to get that genetic test. How are we going to address those type of things? So I think it does have a more public health and policy issues as well that we need to really be looking at over time. Thank you very much.
Okay, great. Next we have Dr. Erin Young, also from the School of Nursing, and she also has an appointment here at UConn Health in the genetics department.
Good morning. I'm going to shift gears just a little bit and talk about a type of pain that we haven't covered so far yet, which is abdominal pain. And I'm also going to talk about studies across, much like Rob did, across the translational spectrum. So we're going to talk about some mouse studies. We're going to talk about translating those into human clinical populations, because I think for pain in particular, proving your relevance, showing that you have something that actually translates well into either prediction or management strategies is vital. So pain is the most common reason for seeking healthcare utilization in this country, and that is across pain type. Excuse me. And one of the main reasons that people actually seek or report seeking medical care, both in the emergency setting and in the general practitioner or primary care setting, is abdominal pain. About 60% of abdominal pain patients that come in reporting abdominal pain have what we call non-life-threatening, unknown etiology, but self-limiting abdominal pain. This is pain that is going to go away. You manage the symptoms, and the patients get better fairly quickly. It's really symptom-focused, and we don't really know what's causing it. It could be a number of different things. Usually, sometimes it's a bacterial infection that can resolve. But about 1 in 10 patients have abdominal pain that is acute and life-threatening. So those are the people who have a disease, they've got something really wrong with them, and we need to treat them immediately. This is peritonitis, pancreatitis, appendicitis, those kind of things. We're not going to talk about those people. We're going to talk about people who have abdominal pain of unknown etiology that may come with another set or cluster of symptoms. And I think these are really interesting patients because about 10 to 15% of the American population it has been diagnosed with something called irritable bowel syndrome, which is not one of these life-threatening acute conditions, and also is not going to resolve on its own, right? And so this is one of the leading causes of persistent or recurrent abdominal pain in both males and females in the US. Irritable bowel syndrome is a diagnosis of abdominal pain with altered bowel habits, and those can be of different types. But the key here is that there has been a shift in the diagnostic criteria for irritable bowel syndrome in the last couple of years. And the Rome criteria are the diagnostic criteria for gastrointestinal disorders. And Rome 3 was in effect until 2016. And in 2016, this changed to the Rome 4, which is a constant updating of how we identify and talk about and diagnose gastrointestinal disorders. So the shift from Rome 3 to Rome 4, I think, is critical to our discussion of irritable bowel syndrome, because it used to be that you could be diagnosed with irritable bowel syndrome if you had discomfort, which is sort of a vague term, or pain that was recurring over the course of at least 3 months, and that was accompanied by alterations in bowel habits, so constipation, diarrhea, a mix of the two, or some unspecified alterations in your bowel habit. But as of the most recent revision, Rome 4, it requires that you have pain. Okay, so this makes IBS a great way of thinking about pain disorders that have no known etiology, because when you look on endoscopy in patients who have irritable bowel syndrome, they have nothing exciting going on. Their colons are very uninteresting, right? So they don't, if they have a disorder, if there is inflammation, if they do have ulcerations, that's something else. These are pain patients. This is a pain disorder with no real cause, no organic disease, and no obvious pathology. So for me, that's really exciting, because the primary unifying symptom or characteristic across all of the subtypes of IBS is the presence of persistent and recurrent abdominal pain. Okay, so we know there are some risk factors for the development of irritable bowel syndrome if you're young and female, right? So this is very similar to what you might see for risk factors or associated factors with other chronic pain disorders of unknown etiology, like fibromyalgia. But you see, if you're young and female, if you have high levels of stress and anxiety, it used to be considered a disorder of hypervigilance, right? So you're anxious, you pay attention to what's going on in your body, you can't see what's going on in your abdomen like the way that you would in the periphery, and so people would focus on that, and they thought of it as more of a pain perceptual condition as opposed to a pain sensory issue. Bacterial overgrowth has also been related, and also alterations. I think we've talked about we're going to see a number of studies today that discuss microbiome. So there are microbiome alterations that have been linked to a risk for irritable bowel syndrome, and also lifestyle factors like smoking and obesity and diet. Some people can see remission of symptoms with dietary alterations. Those don't seem to follow a very specified path, so it's not like every person can cut out wheat and never have another irritable bowel syndrome episode, but some people do see a reduction in symptom severity and frequency with alterations in their diet. The two pieces that I am gonna talk about the most today, because I'm basically controlling for everything else in the animal models, right, is we're gonna talk about family history, which I think of as a way of saying that this is inherited or heritable in a general way, and then also a prior incidence of gastroenteritis, which can be a low-level inflammation of the bowel. Most people who have irritable bowel syndrome can at least think of a time earlier in their life when they had an episode of stomach flu or a gastroenteritis, and they can say, well, my symptoms didn't come until after that period. So there's some evidence that a prior episode of inflammation, even if it's transient and resolves, can be predictive of your risk for chronic pain later on in terms of irritable bowel syndrome. So there have been a few genome-wide studies in humans that have looked at prediction or associations with irritable bowel. And in general, these have overlooked the issue of pain. What they've done is look at associations with other aspects of symptoms related to irritable bowel, so like diarrhea, constipation. What are your bowel habit alterations? There are some that have looked at pain, but most of them have not found significant associations with pain in a clinical population. And this is probably due to the fact that IBS is not simple, right? It's like many other multigenic complex syndromes. It's the result of lots of variations or lots of genetic variation impacting your susceptibility to then environmental factors that may trigger an episode of irritable bowel. So, but there have been some studies that have looked for associations, and they found them between the risk for developing IBS with diarrhea versus IBS with constipation, but not really with pain burden or pain frequency. And I was interested in that piece, right? Because if pain is the unifying symptom across all these subtypes, maybe that's something that we could predict because it's a more stable component between all the different subtypes of IBS. And I like to use mice, at least to start with, because they always show up on time. They eat what you tell them to eat, right? They will let you evaluate them. They are never tardy. And so I use mice. And actually, one of the things that's really incredibly useful for anyone here who's in the clinical setting and not necessarily in the preclinical setting is that we know the genotype of the mice that we use, right? And we don't know that for people who come in. So we can choose mice based on genetic differences or choose mice that have a known difference in their phenotype, which is what I'm going to show you here. And then we can go back to their genotype and look for relationships between genetic variation, regions of variation, and their phenotype. In this case, the development of abdominal pain. So I'm really, I always try to make sure that I unpack how our animal model is clinically relevant in terms of mimicking the key characteristics of the disorder of interest, because I think sometimes this is not always obvious. We actually use, and we'll talk about today, a number of studies that utilize the Zymazan model of transient low-level inflammation of the bowel. So we actually instill Zymazan into the rectum of these mice, and you see a very low-level, transient, neutrophil-based response that resolves within about 14 days, so that at 14 days, the bowel of mice who have been administered Zymazan looks identical to that of mice who have been administered saline. So that would mimic that sort of transient gastroenteritis in your past that has now resolved. And mice are a great model for investigating or looking at individual differences. And here, rather than looking at individual people or individual subjects, we can actually compare strains of mice, because within a strain, those mice are genetically identical-ish. And between strains, they should have known differences or known variations that we can sort of compare the genotypes, looking for relationships between that and different susceptibilities to our phenotype of interest. But not all mice are created equal. And I'm going to show you some data about two very closely related strains of mice that have some key differences that actually result in a phenotypic difference in their susceptibility to pain long term. So for the vast majority of the studies today, we're going to, all of the mouse studies, we're going to use a very similar experimental design in that they have an intrarectal installation of Zymazan under light anesthesia that goes once a day for 3 days, and then the animals are allowed to resolve. And as you can see, there's a transient induction, or there's an induction of a transient neutrophil response that then resolves within the first week or two, usually between 7 and 14 days. And then we can evaluate them for various aspects or phenotypes related to abdominal hypersensitivity. The first piece of data that I'm going to show you is actually abdominal EMG data. So we can, unlike in people where this can be a little bit harder to convince your subjects of, after this transient response is gone, we can actually evaluate how sensitive the mice are to bowel distension by inserting a balloon into the colon and then inflating it to different pressures, non-noxious and more noxious range pressures. And this, usually around 21 days, we see a stable induction of hypersensitivity in some strains. So what we're measuring here, the behavioral outcome that we're measuring in these mice, because you can't say, does your tummy hurt? Right, which is what we say, particularly in kids, which I'm going to show you some data from pediatric populations in a minute. But we actually can measure how much they clench their abdominal muscles. So if there's a visceromotor response to colorectal distension, and the mice have sort of a reflexive clenching of the abdominal muscles like you would if you have an upset stomach, and you sort of arch. And so we can measure the intensity of that response, and that is directly related to stimulus intensity or pain intensity in the mice. This is a little bit of data you can see over on the side. This is 60 millimeters of mercury, which is the highest distension pressure that we use. We use, along the x-axis here, you can see that 15, 30, 45, and 60 millimeters of mercury. The 15 and 30 are considered to be non-noxious range stimuli, so this is normal functional bowel distension. And then I always think of like 45 and 60 as being in the noxious range. So if you've ever had a really bad case of like traveler's constipation or something like that, or you need to eat more fiber, then you might see that that would be in that range. There are labs who distend colon up to 120 millimeters of mercury, which would be highly noxious. So we're more in a lower range for noxious stimuli. And so you can see this is, on the top, we have Jackson Lab C57 Black 6. This is the white bread, right, the standard of research mice. And on the top two panels, you can see that these are baseline measures of EMG activity to colorectal distension. And then 21 days later, which is after that the zymazan response has resolved, you can see that their responses are basically the same, right? There's no difference in their response to the distension of the colon at this time. And on the bottom, interestingly, we have a C57 Black 6 mouse that is from Taconic. Okay, and these originally came from the same founder strain. They were in 2 different institutions for very long periods of time, and due to spontaneous mutations over time, you do see some genetic drift. Okay, but they are both C57 Black 6 mice. So on the bottom, these are from Taconic. This is the control, the saline administered, and this is the zymazan on the lower right. And you can see that in the zymazan, after zymazan treatment in Taconic mice, you have an increase in the response amplitude to colorectal distension. It begins at 30, 15, they're very, very similar, 30, 45, and 60. And this is actually an exemplar of the EMG activity that we have from a pre and a post Taconic mouse at 60 millimeters of mercury. And at the bottom is the pre, the square wave at the bottom is the distension for 10 seconds of the colon. And you can see that as the stimulus goes up, you see an increase in their constriction amplitude of their abdominal muscles. And that, I mean, even if you don't know anything about electrophysiology, you know that the EMG up at the top is showing a much bigger response. And that response is not only larger in amplitude, but also in the number of responses, so the sort of repeated contractions, and also the length of that contraction, right? It sort of is maintained for much longer. We haven't done much at looking at the afterburst part, so after the stimulus goes off, and this data was all collected during the actual distension of the colon. But you can see there's a much bigger response, and it's only after zymazan treatment. So this is showing a strain-dependent differential sensitivity to the induction of an irritable bowel-like syndrome. Now, a C57 Black 6 mouse is not a C57 Black 6 mouse. They're not all the same, right? But they are very, very similar. And so there's a paper published in 2013, this is Zarita, and they actually genotyped 1,400 locations across the genome of the Taconic and Jackson C57 Black 6 mice, and found that there were about 12 locations across the genome that were different in this SNP genotyping. So these are individual polymorphisms, which really mark regions where the mice differ. It gives you kind of if you don't do a lot of this kind of mapping, it gives you a broad estimate of where something interesting might be going on. And I've circled 3 regions that are 3 SNPs that are particularly interesting because they are all in the distal region of a single chromosome. So you can see that the others are all ranging on different chromosomes, but 3 of these SNPs where they were different are out in this distal region of chromosome 10, all right, which no one's falling out of their chair, so maybe I should tell you why I got super excited. Distal chromosome 10 has already been implicated in genetic variation or differences between strains and their sensitivity to formalin pain, which is a similar, an inflammatory stimulus in the periphery on the paw, also capsaicin pain. And there's been a single gene that has been identified as the sort of culprit for that difference, and it's a gene called AVPR1A. This is a vasopressin receptor that is, expressed in many, many tissues. And what's interesting is that in strains that have been shown to be resistant to formalin pain, so this is inflammatory pain caused by a stimulus to the paw, those strains tend to have a higher, so like the AJ, the A mouse from Jackson, has a higher expression level of AVPR1A across a number of tissues, both centrally in the brain as well as in the periphery. So in somatic pain, high AVPR1A expression is associated with resistance. So we looked at peripheral expression of AVPR1A in tissues that we knew would be important for sensory information coming in from the colon, because if IBS is not related to pain processing, but is more related to peripheral sensory input, so maybe the colon is sending more pain messages, or maybe the pain fibers, the afferent fibers that are innervating the colon, respond differently in the presence of distension, then we would be able to see potentially differences in expression in the periphery. And so the problem with the visceral organs is that they don't have very dense innervation, which is why you can't say my left ovary hurts versus my pancreas hurts, which is right. You just say kind of it hurts in this region, right? Because we don't have very dense fibers like we do in the periphery. And so because of that, when you look at the actual number of fibers that are coming from the dorsal root ganglia, so the cell fibers that are innervating peripheral tissues, it's much, much higher. The dorsal root ganglia represents a much higher proportion of somatic tissues than a visceral tissue. So about 10 to 14% of those neurons within the DRG are actually coming from the viscera. And so if you look at the whole DRG, you just grind it up and look at expression, even if you have a huge difference in expression from the actual neurons that are carrying information from your target organ of interest, it could be washed out completely. So you may not see a difference in expression. So we thought, okay, we got to be careful about this. So we actually injected a back label or a retrograde label into the colon so that we only got fibers that were specific to colon. We then took out the DRGs and cultured those neurons so that we could pick up only neurons that we knew had an innervation of the colon. All right, so we're kind of making sure that our sample is actually an accurate sample. And the colon, as many of the visceral organs do, has a dual innervation of both thoracolumbar as well as lumbosacral. There's the splanchnic and the pelvic nerves that carry information from the colon and from the bladder as well and other visceral organs. So we divided this up into lumbosacral and thoracolumbar because it may be that only one of these has a differential expression. It could be, carried entirely by innervation that's going to a single location. And what we found was that overall zymazan, this is Jackson and Taconic, so C57 Black 6, same strains we used before, and this is saline and zymazan injection. What we found was that zymazan decreased expression in the DRG neurons, but it did it for everybody. And because we know we have a differential susceptibility to this colorectal distension, it seemed like, well, this isn't really interesting, right? This doesn't show us what we wanted to see. What we were hoping for is some sort of strain-dependent difference in expression. So the next step was to look at the colon. So this is the innervation. And when we looked at the colon itself, so we took out colorectum from mice that had been administered zymazan, and we waited 21 days, versus mice that had not been administered zymazan, what we saw was that there was an increase in expression of AVPR1A, this is all with PCR, within the colon, and it was only present for those mice that had been treated with zymazan. Aha, right? So the more sensitive strain has more AVPR1A. But wait. That's in direct opposition to what we know happens in the periphery, in the tissues of mice who are resistant to inflammatory-based pain in the somatic tissues. So that's not exactly what we were predicting. But it may come down to, and we'll talk about this in just a second, the difference in the way that those tissues function, what their job is, right? The colon is a very heterogeneous tissue that has a very specific job. And it may be that it's related to that and the impact of those receptors in the colon and non-colon activity. Okay, so this is our expression profiling. So this said, aha, all right, we used a guessing game, a good guess, really good guess, right, to identify our candidate gene of interest, and we see a difference in expression that correlates really well with our phenotype of interest. Let's keep digging. So we know that oftentimes, well, not oftentimes, nobody wants to say often, but sometimes you see a difference in gene expression, but that does not necessarily translate to a difference in the actual presence of the protein target that mRNA should be coding for. So we looked to see if there was a difference in expression between Jackson and taconic mice in terms of the amount of actual AVPR1A, the receptor that was present in the colon. On the left here, this is an ELISA output, and you can see that we have an increase in AVPR1A. So we had increase in AVPR1A expression for the mRNA, and now we have evidence of an increase in AVPR1A protein level in the colorectum after Zymazan. So we see this, again, this strain difference, remembering that taconic is more sensitive in colorectal distension than is the Jackson mouse. And on the right, actually, I'm really glad that Ben Feng is here. There's a beautiful piece of data that he collected showing that if you take the colorectum out with the associated pelvic nerves and you put it in a dish, you can actually stretch the colon and look at the response to that stretch. You can stretch it both laid out flat, so you can stretch it in terms of what would be circumferential stretch, which is like bulging, and you can stretch it in terms of longitudinal stretch. And you can look at the response to that in the presence of the agonist for AVPR1A, which is AVP. So as you can see, you've got white bars that are taconic, black bars that are Jackson, and you have in the same, these are all Zymazan treated, so we waited 21 days, and you can see that in the presence of AVP, that agonist for that protein that we, for that receptor that we know is already overexpressed in these mice, you can see that they have an increased response to the stretching of the colon in the presence of the agonist, but not necessarily under normal conditions. So that means that it's binding to the receptors. It's a good indicator. It's binding to the receptors and causing that difference through this AVPR1A mediated mechanism. That's great. Okay, so what does this mean though, right? It doesn't match with what we see in somatic pain. It doesn't even match with other models of abdominal inflammation. So there's a model where they inject acetic acid into the abdominal cavity and the peritoneal cavity, and you see mice constricting their abdomens, which is clearly an inflammatory or an irritation stimulus. It has the same pattern as what we see in terms of the somatic tissue. So at this point we thought, oh my gosh, maybe this is something that is, I don't know, interesting but not pivotal. So we need to see if this actually corresponds to what we see in our patient populations. And I'm going to show you two patient populations that were collected, one at the University of Pittsburgh and one here at Connecticut Children's Medical Center in their gastroenterology clinic. So AVPR1A is increased in the strains that are more sensitive to this. And so we looked to see if we also saw increases in expression, this increased expression pattern in patients who had abdominal pain, right? Is this a signature for abdominal pain? And on the left, there's a very small cohort of patients that we've collected so far who are pediatric or an adolescent irritable bowel patients compared to normal healthy controls. We took colorectal biopsies from patients who were coming in for endoscopy as part of their medical regimen. The non-pain controls were coming in for normal polyp monitoring or painless rectal bleeding. So they potentially have a condition that requires endoscopy, but they don't have a pain condition. And they had to have pain scores of 2 or lower on the BPI. And IBS, these patients were diagnosed with IBS. They had no evidence of pathology on endoscopy, which is required, right? And we did not divide up based on IBS with diarrhea or IBS with constipation. These are just IBS patients in general. And we looked at expression of AVPR1A within the colorectum, or the rectal biopsies of these patients. And what we found is that the IBS patients had a substantially higher AVPR1A expression profile compared to those patients without pain. So on the right, it's a separate population. We were kind of interested in whether or not this was specific to IBS due to transient inflammation, right? So if the inflammation has resolved, maybe it leaves a scar, essentially, in the pattern of gene expression that results in this persistent pain. But we weren't sure if it was just reflective of abdominal pain or if it was reflective of, the inflammation having been in the past. And so we looked to see if other populations that we had expression from rectal biopsies, if they also showed this similar pattern. And so these are rectal biopsies collected from patients who were diagnosed with ulcerative colitis. Okay, so this is an inflammatory bowel disease that has a very specific pattern of inflammation and infiltration into the bowel, the lower bowel, the colorectum. And we have patients who were in the active phase of disease. Okay, so we have control patients who were, again, there for colon biopsy, colorectum polyp monitoring or for normal colonoscopy. And we took rectal biopsies from these patients. Patients had active disease with no pain and active disease with pain. So these were matched on disease severity, because what you find is that in ulcerative colitis and many, many diseases, you get patients that don't match up, right? So they have raging disease and no pain, or they have very little disease and they're like debilitated by their pain every single day. So those disconnects, we tried to get around those by matching patients on disease severity between the active with pain and active without. And what we found was that the active patients who had pain had a much higher expression of ABPR1A in these rectal biopsies than did patients who had no pain. So the pattern is holding both for from the genomic identification of our candidate gene all the way through expression in different tissues. It seems to be specific to the colorectum, which is interesting because it may actually explain a number of other aspects. And I want to spend a minute, because not everybody's like, oh, ABPR1A, I have no idea what that does. Why would we be interested? ABPR1A is an arginine vasopressin receptor. We know that it is important for stress-induced analgesia in humans and in mice. Sometimes these are sex-specific effects. We have not investigated that sex-specific issue yet, but we know that there can be sex differences in the impact of ABPR1A on pain sensitivity. ABPR1A seems to be a high-priority candidate gene for abdominal pain. Here, we've shown that there's a translational sort of stream showing that it is not just a mouse or systems-related, a model systems-related effect. To me, that seems to make it a really good target for precision pain intervention, because looking at expression as a risk factor means that it is something that I always get nervous when people say biomarker because it's so vague, right? But this shows that ABPR1A seems to be a significant risk factor for the induction of abdominal pain and persistence of abdominal pain. Now, we don't know if it's just for the early phases of acute pain or if it's going to last long term. That's sort of part of the next steps for this. Do you need it forever? So would it be a good marker of people who have long-term chronic abdominal pain that's been untreated, you know? But if we could actually target ABPR1A and knock down that expression and get rid of pain, then you would be able to turn patients who have high expression profiles into patients who don't, right? Functionally. And you could potentially attenuate or significantly mitigate their abdominal pain as a result. Now, we do know that if you stimulate these receptors, that patients, as patients do experience when they are administered vasopressin for, say, gastrointestinal bleed, that when you administer this intravenously, patients really quickly report intense abdominal cramping and pain and also fecal urgency. They tend to have diarrhea as a result. So if you stimulate these receptors, you get a pain phenotype, which is almost like what we would do in the lab, right? For an animal model, we would just give them ABP and see what happens. But you actually see the effect in the clinic. And it's one of the side effects that people live with because they don't want to bleed to death, right? Bleeding to death is worse than abdominal pain. But this may explain that differences in ABPR1A expression in the colorectum or even in other tissues could explain some of the heritable factors, right? Because there are genotypic effects on expression. There are SNPs within the promoter region of the human ABPR1A gene that we know differ between people and also affect expression of ABPR1A and resistance to pain in the inflammatory somatic models that we've discussed. ABP is also released as part of the stress response. And we know that one of the main triggers for IBS is periods of stress. So what if the reason for that is because as part of that stressful experience, you're releasing ABP that's now acting on the ABPR1A receptors that are already increased in expression in the colorectum, right? So now the pain isn't in the head, your pain is in your rectum, your colorectum, which is where it should be, right? So this may also explain altered bowel habits, because if you stimulate ABPR1A receptors exogenously, you get diarrhea and fecal urgency, which are some of the main symptoms of IBS. So for me, this is really interesting because it means that pain is not necessarily a separate pathological process from these other symptoms, but they do travel together. And this could even be part of the profile of, say, mental health alterations, depression, and anxiety that are related to this, because ABPR1A is expressed in the brain. We're going to see tissue-specific differences in expression, but we could be looking at something that, is able to explain a whole host of the symptoms that go along with this painful disorder. Currently, there are at least 2 FDA-approved medications, both that are used to treat low sodium levels in circulation, and these are both antagonists of ABPR1A. if you look at the side effects of these medications, which are administered for, for low sodium, if you look at the side effects, one of them that is common is abdominal pain and alterations in bowel habits, including diarrhea and constipation. So this for me is really exciting because it means that we're not just explaining one piece of this diagnosis. We could actually have implications for being able to explain multiple aspects of this disorder, which until this point were sort of classified under the general diagnosis of unknown etiology. Well, this seems like it's not unknown. Like maybe we have some hints as to what's going on here. And I'm not claiming that this is the only gene that's differentially expressed or the only potential biomarker for IBS, but to me it looks like there's a good sort of stream of data that's showing that this could be, important overall. So I want to thank, there's so many people. This project actually started at the University of Pittsburgh in Dr. Jerry Gebhardt's lab. Dr. Ben Fang is in the back from biomedical engineering here at UConn. So Kyle and Ben and I were all at University of Pittsburgh together. And then Dr. Jun Ho La collected a substantial amount of the colorectal distension data and actually was the first one to start asking some questions about how these two mice that presumably should be similar are not very similar. Matt Coates, Jen DeBerry, and Eva Sigathy all collected data, the human ulcerative colitis data and processing of those rectal biopsies. And then, of course, the lab here at UConn, the UConn team, this is Dr. Kyle Baumbauer, the technician, and all the graduate students are up in the back today. And the CCMC Gastroenterology Clinic, we're working currently on identifying differentially expressed genes that are significantly associated with pain burden in patients who have ulcerative colitis, Crohn's disease, and also IBS. So we're looking at a whole panel of genes that could be differentially expressed, and we've identified some that predict up to 20-25% of the pain burden in these patients. And sometimes there are genes we weren't expecting, which is always interesting. It's funny when science doesn't work out the way you think it will. So, but I have time for some questions, I think. I can take some questions. Oh, good, perfect. Only one, make it
good. Thank you, Erin. I'll compose two questions in one, okay, that can be quickly answered. So I'm curious about the gut localization of arginine vasopressin. So I think not only CNS, but I think in the PNS, arginine vasopressin can be released in gut. And secondly, to close the loop, have you administered arginine vasopressin in your models, and what does it do to gut motility and
So we have a little bit of data that the response to stretch data was ABP administration directly to the ex vivo prep, and we saw that it increased the response to stretching. So we were able to see that those that mice who were in the strain that's hypersensitive, who have more ABP RNA, mRNA, as well as protein, that when you put ABP on it, their colon responds more to the normal stretching of the bowel. So in the presence of the agonist. One of the things that's interesting is that ABP could be affecting motility, right? ABP RNA binding could be affecting motility, which is sort of the coordinated movement of items from one end. Your colon is like the other tubes in your body, right? It's programmed to move things from one end to the other when it's working properly, and that requires coordination with the actual nervous system within the bowel itself. So, in between these layers of mucosa and muscle that are doing their jobs, absorbing and moving, you have this nervous system that's there that is separate from your central nervous system or the other parts of the peripheral nervous system. And it's really contained there. And we could be looking at differences there. We could be looking at differences in the enteric nervous system. It could be in the mucosa. There's really no evidence for differential expression there. It's just kind of ubiquitously expressed. At least that's what the expression profiles that you can find in publicly available databases would say. But that's of interest, right? Because we don't know we know that this isn't happening in the peripheral afferents, but what if it's happening in nervous system tissue that's within the colon itself, and that it's disorganized so that when you stretch it now, it has a bigger response, and you also see increased pain signaling coming from that tissue because now it's hypersensitive to the stretching itself. And so we need to investigate some of those issues, right? It could be that you just have a disorganization or an increased sensitivity to stretch within the bowel, which would explain why people with IBS have painful signaling coming from normal bowel function. Normal distension of the bowel is part of its job. So, we don't know, but I would be really surprised if we didn't see it in a couple of places, right? The bowel is such a heterogeneous tissue that there's a lot of hypotheses to be tested there.
Thank you, Erin. So have a coffee break now until 10:30. I'd like to point out a typo in this. The lunch is listed as starting at 11:30, and that's since the last talk of the morning ends at 11:50. Let's start the lunch at 11:50. Instead, lunch will be provided outside. So we'll convene back here at 10:30. Thank you.